problems. We're going to talk about things that can be problems in the lungs. And we've got, this doesn't want me to present. Okay, I have no conflicts of interest. There's absolutely nothing that I've been able to patent that has anything to do with the lungs or anything like that. So you'll get my honest opinion. Pediatric lung abnormalities, so we can group them in the two main categories, the things that we find at birth or before, and those that are acquired. And, the time of detection for some of these is before birth. You can do ultrasounds that will find a congenital pulmonary airway malformation. You can find a diaphragmatic hernia. You can even see a sequestration. The lobar emphysema is a little bit harder to see before birth because the lung doesn't necessarily inflate. The acquired problems are tumors, infectious, and something I'm going to call traumatic, which isn't necessarily getting hit by a bus, but is something, it's an injury. Okay. CPAMs. Used to be called CCAM, congenital cystic adenomatoid malformations. Those are frequent findings on prenatal ultrasounds, now that we do prenatal ultrasounds a lot. They can be macrocystic, meaning one big cyst, or they can have sort of intermediate cysts, or they can be microcystic. And the microcystic ones that have a proliferation of bronchial structures are hard and firm, and if they grow, they can cause problems like high drops and that sort of thing. But more typically, we have a situation like we have here. Now, are you able to see my mouse? Anyone? Okay.
Yeah, I can see it.
Okay, thank you. So a chest X-ray may or may not show something at birth. This situation, you see a well-outlined cyst, and you can see by the CAT scan that this is relatively unilocular cyst, although if you look carefully, there can be some small septations within there. So this is, the first type, the macrocystic, and those almost never cause problems, and you don't really have to worry about them. The more typical situation is going to be like we have here. Both of these things were found prenatally on ultrasounds, and the chest X-ray is not typically very revealing. It's not very sensitive for the kind of stuff that we see at birth in a CPAM, and so if you get a CAT scan, and I typically delay those until the kids are 3 or 4 to 6 months old because I'm not going to operate on most of these. But you've got these multiple smaller cysts that are lying in the, in this case, the lower lobe. It's awfully hard for me to call on y'all when we're doing this to answer questions, but anyone tell me what we have to do in the vast majority of these cases that have the CPAMs in a situation like this? Anyone? NICU team? I see the NICU team is completely empty. They didn't want to come to this one. Oh, there you are. Okay.
I'm off screen eating. I'm not as familiar. Hey, my name's Gabe. I'm one of the PGY ones.
Okay.
I don't know. I don't.
So this is something. This is something that could very well come across. This could very well come across your desk today. You know, a baby is born with a prenatal diagnosis of a CPAM. What are you going to do? What are you worried about, first of all? You can talk again. First year in the NICU. Turn on your mic.
So I'm worried about long-term complications to see if this child's going to have chronic respiratory issues.
Okay. Well, first of all, you're going to assess the child's breathing at birth and make sure that there aren't any issues that are going to require an intervention. The ones that cause problems are going to cause a mediastinal shift, that they're large, they put pressure on the heart, they can even cause high drops. And so if you have made the diagnosis relatively early in gestation, like 18, 20 weeks, you're going to want to follow the child, you know, relatively frequently, every couple of weeks at first, and then maybe every week after, just to make sure that the lesion doesn't grow relative to the child. These typically can be big enough to cause problems, but the vast majority of the ones that we're picking up now, because ultrasound is so good, are subclinical and probably would never have caused problems in the kids perinatally, even in the past. So we've got this. You can see an area that has no vascularity. So this is the fissure between the upper or the middle and lower lobes here. And so this is in the lower lobe, and this child is going to ultimately require a lower lobectomy because these things don't go away. But that's what we have to do. You've all heard about congenital diaphragmatic hernias, and this is the sequence that we typically have in somebody who's not terribly sick. You can see that there is intestine up in the chest, that the mediastinum is shifted way over into the right side of the chest, and that the child is, you know, I mean, you can't really see that he's intubated, but he is. And with time, you can see that the intestine that's up here gradually is going to reduce down into the belly. This child did not require ECMO, and we'll talk about ECMO sort of separately. And we were able to repair the diaphragmatic hernia. You can see that the lung is still small here. The lung doesn't come close to filling the chest. But over time, the lung grows and fills the chest. And this is still before discharge. But by the time the child is 6 months to a year old, you're going to have a very symmetrical chest, and you're not really going to know that the child had a diaphragmatic hernia. Depending on how big the defect is, you may have worse problems, and the problems you have that are lung related are pulmonary hypoplasia and pulmonary hypertension. Pulmonary hypoplasia is a problem because not only is the ipsilateral lung small, but the contralateral good lung is small too. And if it's all too small, then you may not have enough lung to support life. And in those kind of situations, we may wind up on ECMO, but it's hard to say. We typically, though, have to go on ECMO because of pulmonary hypertension, where the blood won't flow through the amount of lung that we have, and you have to give the child a chance to get over the PPHN. Okay, now Anybody know what a pulmonary sequestration is and the two different types? Let's see. How about I call on Olivia? Are you there, Olivia?
Yes.
You know what a pulmonary sequestration is?
I'm not 100% sure.
Okay. Well, as the lung is developing, most of the time you have the lung buds coming off, branching off the esophagus, and you have the pulmonary arteries and veins supplying the blood to those lung buds and having everything connected to the airway. There are cases that we call sequestrations where the blood supply to a portion of the lung is systemic, meaning coming off the aorta. And so, most of the time, that blood vessel is below the diaphragm. In this situation, you can see a artery coming off the aorta over here and going over to supply the medial aspect of the right lung. You can just sort of tell a little bit on the CT scan that the lung here is just a little bit more dense. And this is what you would call an intra-lobar pulmonary sequestration, meaning one that is incorporated as part of the lung. More often, we will have extralobar sequestrations, which have no connection to the lung at all. They're just sitting there. They look like little masses, and sometimes people will think of them as possibly tumors. And there will have a blood supply that's coming from down below the diaphragm, coming up through here, and just have a little mass that's sitting down like a wedge in either the right or left lower portions of the chest. From a surgical point of view, and we've got intraoperative pictures of that last patient. We've got an unfocused view, but this is the artery that's coming out of the mediastinum and going over to the lower portion of the lung. And we perform a dissection, and you can see very clearly that you've got a big old vessel that's coming through here. In the past, before people recognized just how significant these vessels are, and we're trying to take out the masses, that people would divide this vessel. It would retract into the belly, and the kids would bleed to death before you could get adequate control of the bleeding. And so you have to be very careful to identify all the vessels that are coming into the lung. And you know, it's not all that obvious here that this is a blood vessel. It's only because we're suspecting something that we're looking very, very hard to find it. Okay. Now, we talked about CPAMs and sequestrations as if they are two different things. That's not always the case, that there are intermediate versions of the two. And with that, anytime you've got a CPAM, you need to also be looking for signs of sequestration. What tests, Nisi, would you do to try to look at that? I'm sorry, you just showed up on the bottom of my screen. So if you're trying to find a vessel going into the lung, what tests can you do?
CT. No, can you hear me?
I mean, yeah. Well, what tests can you do that will show you blood flow? for example?
A Doppler?
Okay, you can do a Doppler, and you can do that. So, you know, that's how we pick these things up prenatally. You see the abnormal blood vessel coming off the aorta and going into the lung.
Or a
And
CT
so
angio?
you can do, well, a CT angio, yes, or just a plain old CT with contrast will be adequate to show you this. The CT angio will probably be better because they spend a lot of time fussing to make sure that they can see things. And what I showed you on the previous screen was, in fact, a CT angio. And so you get a very good picture of the vessel crossing in front of the aorta and spine, and going across into the lower part of the lung. Okay. All right, now congenital lobar emphysema. This is one of those rare things that is often associated with an abnormal blood vessel that's wrapped around the upper lobe bronchus, and it leads to hyperdistension of that area. This is a little girl who didn't show up until she was, 4 years old. This is a twin. Her twin outweighed her by 15 pounds. She had some issues, and she had an x-ray that showed a relative lack of lung markings in the upper chest on the left side. You can see normal right upper lung, normal right middle lung, normal right lower lung blood vessels here. And on the left, you have the lower lobe vessels, but the upper lobe has a relative paucity of vessels and has very little stuff actually going through it. And if you take a look on the transverse view, you see that there's, almost no parenchyma there. So it doesn't surprise you when I show you this next nuclear medicine scan. This is a blood flow scan, and it shows that all the blood flow on the right lung is normal, and on the left, there's only flow to the lower portion. This is a posterior view, and so left is on the side that we usually expect the right to be on. And they're very nice because when they do these studies, they will also, educate you by showing you the part of the lung that is not being perfused. And so since this is the posterior view, we're looking at this column here. And you can see that the left upper lobe, this yellow portion, basically has no blood flow at all. By numerical, they got only 6% of the flow in there, and I think that that's probably excessive. You can see that the lower portion of the lung is pretty well perfused and looks pretty good here. Okay. And so what we had to do here was remove the left upper lobe, and there was actually the apex of the lower lobe was also emphysematous, and so we just were able to staple across that. Post-operatively, she did great, and at the first visit, she'd already gained 5 pounds and was doing much better. She wasn't wasting effort on trying to ventilate abnormal lung, and everything was going much better. Okay. Now, y'all, particularly those in the NICU, are going to be encountering neonatal respiratory failure. You know, when folks are, excuse me, I'm giving a lecture right now, Bubby. I'll call you back. So oxygenation index, mean airway pressure times the FiO2 times 100, and then divide it by the arterial partial pressure of oxygen, and you get a number. And in the old days, you know, we just worry about an index of 40, which is pretty bad. This is from Minnesota, and they have broken it down further so that folks who are really, really compromised, we don't have to wait as long. An OI that's high means very high pressures and high FiO2 and low oxygen saturation or low airway oxygen. And if you've got that, then you're really sick. So the sicker you are, the less amount of time we need to make the decision to go on ECMO. Infants who are experiencing barotrauma because the PIPs are really high, the mean airway pressures are really high, or who have hypercarbia despite all of that for a long period of time, or who have an air leak that just can't be managed any other way, are also candidates for ECMO. And kids who just you know, head into the toilet, so to speak, because they are, you know, hovering in this area and then acutely deteriorate, those folks can be considered for ECMO earlier, or a precipitous deterioration. You don't have to wait as long to do it. Okay. This is a typical situation. We can have meconium aspiration, used to be the most common reason for needing ECMO. That was 80–90% of the ECMO requirement back in 1985. Whereas more and more we see that diaphragmatic hernia and pulmonary hypertension and maybe even sepsis are more and more common because, or at least as a fraction, because meconium aspiration is much better managed today with all the fancy new ventilators you've got, and so we are able to manage those kids better. You can see that this is a child whose lungs are not good. You can't tell what the ventilator pressures are. You can't tell what the FiO2 is, but it's getting, things are worsening. And so we chose in this case to put the child on veno-venous ECMO. In order to do veno-venous, you have to have a normally functioning heart, and this child did. And so we place a single cannula in the right atrium and draw blood out of the end and through side ports that are over here. And then the blood that returns comes out medially and squirts toward the AV valve, the tricuspid valve, and allows preferential oxygenation of the blood that's going through here. That improves the pulmonary hypertension by reducing pulmonary artery pressures. Oxygen is a great way of reducing pulmonary artery pressures and in allowing the lungs to get better. Having said that, it's very typical after you go on ECMO to have this whiteout situation. And during the whiteout, it's in part because you have decreased the barotrauma, decreased the ventilator pressures to allow the lungs to start healing themselves, and you let the ECMO take care of most of the oxygenation needs of the child. Ultimately, the goal is to get to this stage where you are able to remove the cannula and have good oxygenation. You actually have to have the good oxygenation first, and then we can remove the cannula and move on from there. Okay. Now, is there a question?
Yes, I have a question. This is probably a really basic question, but since we don't see ECMO a lot, I know you talked about VV ECMO there. When would be a situation that you would use VA ECMO?
Most of the kids that we have are going to get VA ECMO. We have a lot of kids who wind up on ECMO for diaphragmatic hernia reasons, and those guys typically have some cardiac dysfunction as well. Everybody who's going to get ECMO is going to have an echocardiogram ahead of time, and if the echo shows significant cardiac dysfunction even before we go on ECMO, then they're going to get VA ECMO. Kids who are septic are likely going to need VA ECMO because their hearts just aren't going to be able to continue to support everything. So the vast majority of the kids that we put on these days are going to be VA. VA used to be the standard. Then we tried to do VV for everybody because we didn't like the idea of ligating the carotid artery. You can understand that, but most of the kids who have the carotid ligated are going to do just fine afterwards, and you can't tell neurologically that there's a problem. Certainly when they get older and have been smoking and basically being adults, that they may have carotid artery disease, and if you've only got one carotid artery, then your risk of strokes and other problems is going to be higher. I expect that we are going to start seeing people who have been on VA ECMO since this happened back in 1980. The first patients were 40 years into this, so we're just going to be getting to see complications, long-term complications of ECMO in the next 10 or 20 years. Okay. Did I answer your question?
Yes, thank you so much.
Okay, thanks, Chris. Okay, infectious. Empyemas. You've all seen x-rays of folks who have pleural effusions, right? Okay, so a pleural effusion may or may not be an empyema. That when we have a pleural effusion, we generally will ask you guys to get an ultrasound. And the reason we do the ultrasound is to tell us whether there is a simple or a complex fluid collection. If there are a lot of septations, then a simple chest tube is not going to be as effective at draining the fluid as it would be if it's simple. With a chest tube, though, you do have the option of using TPA. You can put TPA in there, and it will break up some of those loculations and help you get things drained. But in situations where things are really thick and nasty, and the child is having some compromise that needs to be dealt with more urgently, then thoracoscopy is a very good way of dealing with that. Have any of you all ever seen bronchiectasis?
Yes, mostly in our kind of refractory CF kids.
Okay, well, in the refractory CF kids, let me go back here. That surgery is not typically something that we suggest for those folks. In the old days, meaning before I was a resident, bronchiectasis was much more common as a long-term sequela of inadequately treated infections. Maybe there were some folks who had CF partial penetration or something like that, would wind up with areas that were ectatic. And by resecting that portion of the lung, usually it was medial right lower lobe, you can get rid of the ongoing infectious source and then take care of that. And abscesses are things that you guys will see fairly frequently as well. Those are often going to be seen in folks who have staph or strep pneumonias and then wind up with a big old fluid collection within the lung. Surprisingly, those heal pretty well and we don't have to drain most of them, but some of them will drain spontaneously into the chest and we will have, at least temporarily, a bronchopleural fistula. We had one not too long ago that we put a catheter into to drain and to control it until it had a chance to scar down and for the lung to start healing. Sorry I don't have pictures. I actually thought I was giving this lecture tomorrow. But okay. And then we have pneumothorax. And this is a patient who's currently hospitalized, came in yesterday. And, we have, sometimes we've got spontaneous pneumothoraxes, sometimes we've got it because of lung disease, and some because of trauma. Any thoughts onto what the likely cause is here? I'll ask Mallory, since I haven't picked on her yet.
You're asking what the cause is for which of these images?
For the pneumothorax. I mean, this is the same patient. This is pre-treatment and post-treatment. So do the lungs look normal?
No.
Okay, so he's got lung disease. And this is somebody who, was diagnosed with COVID acute a couple weeks ago, seemed to get better, and then had a recurrence of symptoms and significant chest pain. Had a chest x-ray, which you see right here. And this would be a greater than 50% collapse of the lung. If you have a little tiny pneumothorax, you might want to observe it and not put a chest tube in, but with anything that's greater than 30 or 40%, you're probably going to want to put in a chest tube to get it to expand. This tube was placed down in the emergency room, and you can see the lung has expanded, but you've still got parenchymal disease. Kids who are coughing because of lung disease may have areas that are weak in the lungs, and certainly the coughing can be very vigorous and lead to the perforation. What we more typically see are the spontaneous pneumothorax in the tall, thin adolescent guys. And many of them will have a connective tissue disorder, Marfanoid habitus, is going to be the situation. I will say that there is a little disagreement about how to manage the first pneumothorax relative to other pneumothoraces. If you've got two on the same side, I don't think there's anybody who would advocate non-operative management for that. But in some folks who have a relatively mild pneumo and don't have an obvious connective tissue disease, that you might want to manage them expectantly with 100% non-rebreather mask. The reason for that is if oxygen leaks out into this cavity, then it's going to be absorbed across the pleural membrane. And if the hole is small, then it's going to seal. And that can be without a chest tube. If it's small and you put in a chest tube and the chest tube stops leaking quickly, then you have the option of managing that expectantly as well. Since we have gotten very good with chest CT scans, I think that the surgeons in our group would want to get a CT of the chest in these kids the first time they come in, because if they've got a significant bleb that's visible at the apex of the lung, then resecting that can take care of the problem, and you know that the bleb is going to pop and leak and cause another pneumothorax in the future. In the days when we only had chest x-rays, expectant management made more sense because you didn't know whether there was a bleb or not. Not everybody will have a bleb, but most people will. And if we can identify it with a CAT scan, I would suggest that we go ahead and go in and thoracoscopically resect that apex of the lung. And then, of course, we as surgeons see the folks that have been involved in trauma. And having had a pneumothorax myself from trauma, it's not much fun. You know, I did insist on the smallest possible chest tube. Because I was a surgeon, they shut me up with Versed, but respected my wishes and put in a tiny little pigtail instead of the typical 30 French trauma chest tubes that they put into most of the trauma patients. And I only had a pneumo. I didn't have a hemopneumothorax, and so didn't need the extra there. Okay. And as far as tumors go, there's something called a pulmoblastoma. And that's something that's going to look on CAT scan a lot like a CPAM. It typically is not something that is congenital. And so I have not routinely operated on the CPAMs early if they were found prenatally. But it does give you some anxiety when you're watching a CPAM. A pulmoblastoma is only about 1% as likely as a CPAM, and it's going to be something that is best resected early. If it gets to the point where it's metastatic to lymph nodes, it's going to be unresectable, and we don't have any good chemotherapy for that. I had the opportunity to see a child with carcinoid, and let me see if I've got the pictures here. No, I do not have the picture here. I'm going to pull it up from my file here. Okay. So we have this young lady who has a tumor in, it's a bronchopulmonary carcinoid tumor. It's sitting in the airway, and let me close this and we'll open this. And you can see this is the left main stem bronchus coming down here to the left lower lobe bronchus. And you can see that the bronchus is narrowed, and you can actually see the carcinoid sitting in it. It's just a little over 1 centimeter in size, not all that big, but it is something that has caused complete collapse of the upper lobe. And I'm going to show you this one last picture. No, that's not it. The nuclear medicine picture. You can see that even though it's only totally collapsed the upper lobe, that there is almost no perfusion of that left lung at all. And but we went in with the goal of resecting the upper lobe, but found that there were a huge number of lymph nodes around all of the mediastinal structures, and were very densely adherent and inflamed. I mean, these lymph nodes were 1.5 centimeters to 2 centimeters in diameter. And we made the decision to just perform a total pneumonectomy. And, you know, it's under the circumstance, you can see that 91% of her blood flow was already going to the right lung and only 9% was going to the left. She tolerated the pneumonectomy amazingly well. And within a month after taking out her lung, she was running stadiums for soccer practice. So, you know, it's a sign that she had this for long enough that she had already compensated for it. She was only 13 when we found this and removed her lung. We also used, because we were doing a fairly big thoracotomy, we froze the intercostal nerves on that side and gave her a 3 to 6 month nerve block afterwards. And so she was exceedingly comfortable, and her only complaint was that she had some numbness in the left chest and breast that was annoying to her. But she was completely functional and was able to do very, very well. So carcinoid, we've got this picture here. And then we have the metastatic diseases. Is anybody here interested in oncology? Anybody who's watching? How about the person who's in the HEMONC classroom? You know, you're going to have to step up here and tell me what you think.
I'm not sure if oncology is my calling.
Okay. Well, it doesn't have to be your calling. It's your avocation right now while you're watching this lecture. And so we have recently had a patient with osteogenic sarcoma. Were you on service when that operation was done?
No, sir. I started 2 days ago.
Okay. All right. Well, can anyone tell me about osteogenic sarcoma and the lungs? The lungs are a common site for osteogenic sarcoma to spread. So is Chris coming to the No, okay. Someone going to speak?
Chris,
I mean, the lungs are a common place that it can metastasize to. So you
Okay.
often end up doing a resection.
Okay. And can those resections be curative?
I honestly don't know the answer to that. Most of the patients I've seen who have had resections have had advanced disease and have not ultimately done well.
Okay. It depends a bit on how many metastases there are. If there are a lot of metastases, particularly if they're bilateral, that the likelihood of cure is low. One of the nice things about these is that with osteogenic sarcoma, the nodules are easy to feel, and at least right now, our current recommendation is that you do an open thoracotomy to resect them, because you can find more lesions just through sense of touch than you can always see on the CAT scans. Having said that, the CAT scans are getting better. Most of these are very close to or on the pleural surface, and you can see them thoracoscopically. But we do not have an agreement in the surgical community and don't have a whole lot of data as to whether a thoracoscopic resection for osteogenic sarcoma is equivalent or better or worse than the open operation. The open operation is still the gold standard. Okay. And if you can resect a couple, you can many times get years of disease-free survival, even if ultimately the patient will die. And multiple thoracotomies or thoracoscopies may be necessary to get you that far. I mean, I have operated on kids who had problems when they were early in high school and have continued doing resections well into college and afterward, so that you're giving them longer life and improving the quality of their lives by doing the surgery. Wilms tumor.
May I ask a question on that
Yeah.
last? At what point do you say their pulmonary function is too decreased that you can't do another resection?
Well, I mean, you can do pulmonary function tests. Most of the time, we're taking out relatively small bits of lung. We're not taking out lobes at a time. We're doing little wedge resections that are very superficial, and the lung can compensate to a certain degree in between. I mean, you can take out 50% of somebody's lung volume and still have reasonably good lung function. And if you're taking, 5 or 10% every couple of years, you may not get to a point where the lung function is what limits you. I will say that every time you operate, you create scar tissue, and it becomes harder and harder to go back in and do repeated operations for that. Wilms tumor, we will have metastases to the lungs there. What typically is the treatment for lung metastases in Wilms tumor?
Radiation?
Radiation, yeah. You get, if you've got spread in the belly, then you wind up getting belly radiation. If you've got mets in the chest, then, and multiple mets anyway in the chest, then you will get lung radiation. There are times when we as surgeons will be asked to do a biopsy because not all lung lesions in Wilms tumor patients are going to be metastases. Certainly, there are parts of the country where little fungal infections, little granulomas can be relatively common, and you don't want to be in a situation where you're going to radiate the lungs if you can avoid it. And so we may do a diagnostic rather than therapeutic biopsy in Wilms tumor to help sort out whether it really is metastatic disease. And once again, CAT scans have helped. And then hepatoblastoma and hepatocellular carcinoma. There, we typically are not going to be operating on the lungs. That hepatoblastoma is potentially curable even if it is metastatic to the lungs. You would give the chemotherapy, and many times that will improve, and you won't have any residual tumor in the lung. Whereas with hepatocellular carcinoma, if you've got a few metastases and the tumor is resectable otherwise, you may actually want to go in and resect the lung mets, because without complete resection, hepatocellular carcinoma is not curable. Okay, so that's kind of it. I was going to present you with some clinical cases, but I think that we're okay. Now, do people have questions? Anything? That we're always available to help. That certainly the pulmonologists will be involved with some of these, but some of these are more surgical diseases, and we need the pulmonologist after we resect some things, and, or repair a diaphragmatic hernia and things like that. So, any other questions? Okay, well, thank you very much.
Thank you, Dr. Atkins.
Take care. Bye-bye.